So in standard reading, increased ventricular parietal thickness, increased ventricular volume, increased cellular hypertrophy, and increased scar formation will affect the QRS complex. Conduction delay will affect the duration of PR interval and QRS interval, while high filling pressures affect the P wave. Decreased subendocardial perfusion lead to T wave abnormality. In cardiomyopathy oriented reading, increased myocellular content and volume, effect of the disease process on myocardium and conduction system affect the QRS complex, whereas interstitial expansion and fibrosis, topography of the myopathic process will affect the T waves. Increased left ventricular wall thickness in lysosomal associated proteins, there would be very high QRS voltages in cardiac amyloidosis. End stage hypertrophic cardiomyopathy, there would be low QRS voltages. In Anderson-Fabry disease, there would be right bundle branch block. In apical hypertrophic cardiomyopathy, there would be giant negative T waves. In sarcomeric hypertrophic cardiomyopathy, there would be Q waves with positive T waves. And in Anderson-Fabry, LAMP2, PRKAG2, Pompey's disease, and mitochondrial disease, there would be WPW pattern. And in cardiac amyloidosis, late Anderson-Fabry and myotonic dystrophy, there would be AV block. Dilated phenotypes, there would be low QRS voltages in arrhythmogenic cardiomyopathy, mainly ALVC, filamin C cardiomyopathy, phospholamban-related cardiomyopathy, sarcoidosis, and hemochromatosis. In laminopathy, there would be left bundle branch block. In arrhythmogenic cardiomyopathy or dystrophin-related cardiomyopathy or sarcoidosis, there would be right bundle branch block. And abnormal negative T waves, if they are anteriorly seen, they would be ARVC related. If they are inferiorlaterally seen, they would be related to ALVC or filamin C cardiomyopathy. AV blocks are usually seen in laminopathy, Emery-Dreifuss 1 desminopathy, and myotopathy. If you see right bundle branch block in precordial leads V1, V2 with peripheral leads in D1, AVL, and AVF, there is chance of ARVC. In epsilon waves, if you see them in precordial leads or in peripheral leads, this is ARVC. If there is Brugada pattern, Brugada syndrome, Brugada pattern is seen in precordial leads mainly. Fragmented QRS is usually seen in ALVC or biventricular cardiomyopathy. So that is it for today.